I'm Dr. Keith Loud. I'm the physician-in-chief and chair of pediatrics at the Children's Hospital at Dartmouth-Hitchcock, which we call CHAD. This evening, we will be hosting a panel discussion to answer your questions and concerns regarding children and the COVID-19 vaccine. I'm really pleased tonight to be joined by several of our Dartmouth-Hitchcock experts. Joining me is Paul Palumbo, a pediatric infectious disease specialist at CHAD in Lebanon.
Good evening. As Keith mentioned, I'm an infectious disease trained pediatrician that I've been working in the Upper Valley at CHAD since 2006, I believe. So about 15 years. Happy to be here.
Thanks, Paul. And we have also Mary Bender, a general pediatrician at Mount Ascutney Hospital and Health Center in Vermont.
Happy to be here.
Thanks, Mary. And from the southern part of New Hampshire, Ellie McGuire, a primary care pediatric nurse practitioner at CHAD in Nashua.
Hi, everyone. Thanks for inviting me to be part of the panel. And I'm glad to be part of CHAD and hope to answer some of your questions this evening. Thank you.
Thanks, Ellie. We have Peter, Paul, and Ellie tonight for those who might catch the reference. So I want to thank Peter, Paul, and Ellie, and all of you for joining us tonight for this discussion. I will clarify a few housekeeping items for all of us before we get into the questions. So the session will be recorded and made available on the Dartmouth-Hitchcock YouTube channel following the end of the discussion, so you can review it again. At that point, we will also have closed captioning available, as we do not have the closed captioning feature, unfortunately, through Facebook Live. You can, however, submit your questions through the Q&A box. If you've noticed that, we'll try to get to questions tonight. And if we are unable to do so, you can submit them to chad.community.relations@hitchcock.org. And we will try to respond to those within 48 hours as well. So we'll get right to it and have the first question to Ellie McGuire. Ellie, it's understood that COVID-19 does not affect children as significantly as it does adults. And as a result of that, why should children receive the vaccine?
Well, I have two sort of short answers for that. One is to keep them safe. And the second part of that is to help them then reduce the risk of transmission to family members, other community members, and overall just reduce the incidence of COVID-19. It's true that fortunately, children are less likely to have severe illness from COVID-19, but it does still happen. And as we've seen more of our older population be vaccinated earlier, justifiably because they were at greater risk, we're now seeing the average ages of hospitalizations dropping. So it makes sense that we might see more hospitalization, not rates, but we might see, it might look like the rates for kids are going up. Fortunately, those have stayed low, but the risk of significant illness does exist, even for healthy kids, and same as with adults for kids with risk factors like obesity, congenital heart disease, asthma, some of the other pre-existing conditions. We know that more kids have been hospitalized with COVID-19 related illness than kids during the H1N1 flu of 2009-2010. So I think in general, it's a good way to keep your child safe, avoid those risks of serious illness for them, as well as for your family, friends, and other community members.
Thanks, Mary. Thanks for the, as you say, the focused and quick responses. We'll get to a lot of questions as we answer our questions as succinctly as we can. Our team is great that way. So Paul, about 52,000 or almost 37% of children in New Hampshire between the ages of 12 and 18, and 30,000, already more than half of children of that age range in Vermont have received at least one COVID vaccine. Can you provide a brief explanation of how the COVID vaccine works? And then as you're discussing it, how we know it is safe and effective in teens?
Well, first of all, Keith, it's really exciting and gratifying to see the quick uptake, at least in a sizable fraction of 12 to 18-year-olds of the vaccine once the Pfizer vaccine got approved for this age group. There's still more to go. And that's part of the work of this panel, is to try and encourage folks out there to participate in the youth vaccine initiative here. So these vaccines are really a wonder of modern science. All vaccines have a pretty similar goal, and that is to train our immune system to fight the infection of interest, in this case, COVID. The Pfizer and also the Moderna vaccine are what we call mRNA vaccines. So they're a fairly new category of vaccine. They're not totally new. They've been around for a while, and there have been multiple infections that vaccines have been developed using this technology, this mRNA technology. What the Pfizer vaccine does is takes the genetic information for a protein from the virus and provides that to the host or the human cell to make that protein, which the immune system sees and is trained to fight. So it's basically a really neat strategy to make viral proteins or a viral protein in a human cell, which then allows the immune system to attack it, to identify it and attack it. This information that is part of the vaccine is degraded and done away with once it's used, so it doesn't stay in the human body. So it's a one-time effort to train the immune system, and it's a long-lasting effect. Once the immune system is trained, it is trained essentially for life. So again, a very exciting scientific development. We've all been very impressed with how quickly, but I would say efficiently, this vaccine was generated.
Thanks, Paul. I have see some questions already in the Q&A. We will weave those in. I'm gonna take the first one, which was a question about state vaccination sites starting to close down over some places. Where can kids age 12 plus go for the vaccine? There are still sites in both states, Vermont and New Hampshire, which you can find online, but healthcare providers are going to start to get into that game as well. And Ellie McGuire reminded us that DH Nashua is opening its first COVID-19 vaccine clinic in the Nashua site as of Friday afternoon, and we'll have twice weekly clinics on Tuesdays and Fridays. Dartmouth Hitchcock Medical Center in Lebanon has conducted clinics as well. We will keep these updated as best we can at dartmouthhitchcock.org and chadkids.org, but good question from the start. I'm going to now go to Dr. Bender. What do we know about dosages for children, Mary? As one parent recently put it, some of these 12-year-olds weigh as little as 60 or 65 pounds. So will they be given the same dosage as a much larger adult?
Keith, that's a really good question. I guess the first thing I'd like to say is that I think that all of the parents on this call deserve a gold star. I find that it's the most conscientious, thoughtful, caring parents who have lots of questions about vaccines and other therapeutics. So I applaud every parent who's tuning in. And I also think that they should get a special gold star because it is so hot at this moment. And I think the majority of parents would far rather be cooling off somehow. So strong work for everybody that is on this call. So interestingly, with vaccines, generally speaking, the dose is the same for adults and kids with just about all of our vaccines, with the exception of the flu shot. For very young kids, our under 3-year-olds have a slightly lower dose, but it's actually pretty typical of vaccines for the dose to be the same for kids and adults. I mean, I think in general, it is a bit of a balancing act, right? You want the dose to be high enough to provide a really robust immune response, and you want it to be sort of low enough that you don't get a lot of side effects, bearing in mind that often side effects are a result of the immune response to the vaccine. So the dose is really tiny. It's 0.3 mLs, which is about a 1/100th of 1 ounce. And I do believe that, Paul, you'll know better than me. I believe that with some of the vaccines are looking at for under 2s and under 11s, that they may be looking at slightly lower doses, but just generally speaking, a dose for kids and adults of a vaccine is pretty typical.
Very well said. You're right. The vaccine dose for other vaccines and this one often are the same between adults and children. Pfizer does have in the field right now studies looking at their vaccine in children under 12. And they're looking at 3 doses. So the dose that we're giving to teens and adults is 30 micrograms, but they're looking at 20 and 10 also. So they're looking at a range of doses in 5 to 12-year-olds and in 2 to 5-year-olds. So that's going on as we speak. They're doing what's called a dose finding study to see what works best in those under 12. It's very possible that the 5 to 12-year-olds will have the same dose as those who are older than them, but we'll find out the data, and we expect this data by the end of the summer.
That's great. That's great. So Ellie, routine vaccines, as we know, are an incredibly important part of keeping our children and the community safe in general. Do we know yet if the COVID vaccine will become a once-a-year vaccine like the influenza vaccine, or perhaps just a booster dose? And what do we know, if anything, about school entry requirements at this point?
I think that's one of those really hot topic questions on this vaccine. And I think right now we don't exactly know. We have our current schedule for the 2 doses. We're still learning about how long that duration of immunity is going to last. We know with illness, you're not likely to get reinfected for about 90 days, although there have been some reinfections. And the mRNA vaccines provide protection for about 6 months, probably longer. But we're going to have to watch, and studies are looking at exactly how long that immunity lasts. And the duration of immunity can be affected by a variant coming up and necessitating a change in the content of the vaccine. You think about the tetanus shot, it's the same tetanus shot, and you only need your booster every 10 years, but your flu vaccine gets tweaked every year or 2. And, we may need to do that with the COVID vaccine as well. I think the more people we can get vaccinated, potentially the lower risk for variants developing, if we can just reduce the overall incidence of illness, and maybe that helps us reduce or impact some way the need for a booster. So right now, no specific data, although I know that's being looked at closely by the manufacturers and bodies like the NIH. So certainly more to come, but we should still get those first 2 doses in, and then we can tackle the booster dose. School requirements are established by states, not usually by the federal government. I think the smallpox vaccine, for anyone, probably everybody else on this call is younger than me, so maybe nobody else remembers that. But I think smallpox was one of the only vaccines that was ever federally regulated in terms of who's going to get it or not. So right now, those school requirements are established by your state. New Hampshire and Vermont both have what are called medical exemptions for kids with medical reasons not to receive a vaccine, and religious exemptions. So, we'll see what the state decides, and then would follow those guidelines. I don't know how the FDA full approval versus the emergency use coverage would impact, but I'm sure that needs to be considered as the state establishes those parameters. So more to come on whether we'll need a booster or not.
I'm sure that'll be a robust discussion, the school decision, and people will have the opportunity to participate through the representative legislative process, I would suspect. But as we're talking about boosters and routine immunizations, because Mary and Ellie, more than I practice with adolescent medicine, are also working in all of the routine standard childhood immunizations. A question did come across, Paul, about spacing of the COVID vaccine from other vaccinations, which we've tried to avoid. Anything developing in that front in terms of rotating those in the COVID into the routine childhood schedule?
Yeah, there's some really good new news about that. When the vaccines were initially studied, the trials were set up to separate the COVID vaccines from all the other routine vaccines that an individual might be eligible for. So there had to be at least a 2 to 4 week window where no other vaccine was given. So that's how things started with the trials. Now that we've gotten a lot of experience in real life out in the field with literally millions of people, it's become very clear that it's safe and possibly even desirable to co-administer the COVID vaccine with routine immunizations. The CDC and the American Academy of Pediatrics, among others, have come out strongly in favor of co-administration of vaccines if that's on the table for any individual. So we can give them together at this point. It's much more efficient and it creates a situation where it's more likely that people will get the appropriate vaccines that they need.
Great, we can work them in. We can work them in. Mary, what about children who have chronic conditions though? Are they still eligible for the vaccine? And how about those with food allergies? Sorry to throw two questions at you at once.
That's perfectly fine. Yeah, so actually we want kids with chronic conditions to get vaccinated. It is true that overall children do better than adults and tend to have milder disease with COVID, but about 300 kids in the US have died of COVID. And there was a study looking at the kids who died between February and July, these 121 kids who died, and the majority of them did have chronic conditions, including asthma, heart disease, neurologic and developmental delays, obesity. So I think it's actually very, very, very important for children with underlying illness to be really at the head of the line to get their vaccine. In terms of allergy, of course, we have got lots of kids with all kinds of allergies to foods and pets and bees and environmental allergies. That's not a contraindication to vaccination, but we do actually ask that typically after a vaccine, you wait about 15 minutes to make sure that you haven't had any particular reaction. And with the kids who have underlying history of allergy, we actually ask that they wait a half an hour. I would just say that my experience is that the biggest issue with teenagers and this vaccine is they faint. So an occasional kid after getting a vaccine will faint. So I would just suggest that if anyone starts to feel a little woozy after a vaccine, it would be a great idea to put their head between their knees or lie down. So that's the side effect that I'm seeing more typically, honestly, and it's just good to be a little forewarned.
Mary, I assume that youth fainting phenomenon is not specific to the COVID vaccine.
No, it is not. That is very common. We see it all the time.
Yes, my colleagues also recall as we started rolling out the very important HPV vaccine in teenagers that we were reminded we need to have those teenagers, boys and girls, seated on the exam table or lying down. So that's not particularly unique. What might be a little more unique is we've heard recently reports, Paul, and even the AAP sent an alert to pediatricians today about 7 teenage boys across the entire United States demonstrating myocarditis, perhaps heart inflammation after vaccination with the Pfizer BioNTech vaccine. What's the early thinking on that?
Well, this is reminiscent of the blood clotting issue that arose in a very, very small number of women who received the J&J or AstraZeneca vaccine. As you recall, the J&J vaccine administration and even AstraZeneca was halted for a brief period of time while expert panels really carefully reviewed all the data and concluded that it was safe to continue to go forward because of the very, very low rate of this complication. So recently, as you said, Keith, there was a report from a group of pediatricians or physicians who had individual young men, these were teens, who developed mild myocarditis. It was reversible. They got over it fairly quickly, but point of fact is that there are reports of 7 young men now who've had myocarditis close to the time that they received the COVID vaccine. It's pretty clear at this point that we do not know if it's related to the COVID vaccine. It is very low. It's occurring at a very, very low rate, probably 1 in a million or less than 1 in a million. So there is, the gratifying part of all this is that there is very close oversight of any side effects, in particular more serious ones, that may occur around the time or after immunization with COVID vaccines. So this is going to be followed very closely. All the experts at this point feel the risk of stopping or not immunizing is much higher than the risk of immunizing. So there's still a strong green light for immunization of boys in their teen years. But this is going to be followed very carefully, as the previous example with the blood clotting. So stay tuned on this, but there's no diminishing of enthusiasm for immunization at this point, based on these very early studies, which have stimulated very close observation and follow-up.
Thanks, Paul. And some on the call, appreciate that one of the concerns about SARS-CoV-2 infection, which causes the COVID disease, is in fact myocarditis or a multi-system inflammatory syndrome in children, also extraordinarily rare, but still, I think, as Paul said, the balance is that the vaccine will prevent those outcomes. And so the balance is still there. Thank you. Ellie, what, in the meantime, as we think about younger kids, what precautions should children, parents of those children under 12 and those children themselves actually take until they are eligible for COVID vaccination?
I think my first thought is get everybody who can get vaccinated. That's key number one, to keep those younger kids as safe as possible. And for the younger kids, get them vaccinated with anything they need and are eligible for. Everybody's office is open. We've got safety steps in place. It's safe to come in. We want to get everybody back on track, and nobody should be worried about coming into the offices. We have strategies, no matter whether it's Dartmouth or any place else. We all have strategies to get these kids taken care of. So come in and get whatever you need done. And then when it does become available that your child can get the COVID vaccine, they only have to get the COVID vaccine. They don't have to catch up on everything else too. So those would be my first 2 thoughts on how to keep younger kids safe. And then I think you have to follow your local public health guidelines, because even though we have lifted the mask mandate here in New Hampshire, some different communities or different organizations still have their own parameters in place. Certainly wearing masks for kids over 2, if they're out in public places where you may not be sure if they're going to run the risk of being exposed to unvaccinated people, is still a wise idea. Parents, although they may not need to wear that mask, maybe they've been vaccinated, modeling appropriate, timely mask wearing for young kids is going to be really important, and to enlist their older siblings who also may be able to be unmasked, to get everybody involved, because we know younger kids will follow along with that much more easily. Simple, basic precautions. washing your hands, a good 20 seconds with soap and water, or using hand sanitizer with 60% alcohol concentration when needed. And we always need to supervise the younger kids, particularly under 6, with hand sanitizer. And they want to cover their whole hands and really rub that sanitizer in till it's dry. So washing if you've been outside to the store or out in the playground, keeping social distance still in place in those high-risk settings. Cover your nose and mouth, cough into your elbow, and keeping up with your routine care. So I have found a great graphic on the CDC website, which helps families kind of navigate. We're vaccinated, they're vaccinated. What do we do? We're vaccinated, they're not vaccinated. What do we do? When can we safely socialize with people in our close pod or close family members? And so I found that one pretty helpful because situations change. So I think get your vaccines. COVID vaccine for those who are eligible, all the routine vaccines for those who aren't COVID vaccine eligible yet. So we have them primed and ready for when the day is available for them.
Ellie, it's summertime and the camps are looking like they're going to open. Are you aware of what they're planning?
I've been asking families. A lot of them are, because they're outdoors, they're smaller numbers, and some camps are going to allow the kids to be mask free. And certainly for water related sports, that's going to be a safety issue as well. So I haven't had a whole, and certainly if you're outdoors, it's much safer than if you were indoors, in those settings. But I have had a few people going to camps. I haven't had my usual number of kids going to camps yet.
Yeah, and the CDC has been giving updated guidance for camps recently because of the importance of socialization and the importance of camps for kids. Dimitri Christakis, editor of JAMA Pediatrics, has been a strong proponent of schools and camps. Excuse me. Paul, you had alluded to the dose finding studies for the younger children under age of 12. And just could we elaborate a little bit more on that? A couple of questions have come in terms of what do clinical trials look like in general, and in terms of also the 12 to 18-year-old population, Moderna and J&J vaccine approval. So to reassure people on the safety and efficacy of trials, a little bit on how those look?
Sure. So whether it's development of a medication or drug, or whether it's development of a vaccine, the typical path is there are a lot of studies that occur before the vaccine even gets to any humans. So they're done in the laboratory, they're done in animals, et cetera, to try and develop some sense of safety and also how effective they might be. Then the next step is to try the vaccine in large numbers of adults. So the adults go first. Usually it's 18 and above. For Pfizer and a couple of the other vaccines, they started at age 16 and above. And they did very large phase 3 trials. Approximately 30 to 45,000 individuals were enrolled in each of those frontline studies in adults. They quickly generated the data, the information from those trials, submitted it to the FDA for approval. Once that happens, once the vaccine is proven to be safe and effective in adults, then they're encouraged to quickly move into pediatric populations. As we saw with Pfizer and now Moderna, the next step was to go for the 12 to 18-year-olds, and both companies have finished trials there. Moderna's trial has been submitted to the FDA, and we'll probably see an approval for 12 to 18-year-olds with the Moderna vaccine fairly shortly. Both companies, both Pfizer and Moderna, have active trials in the field now looking at even younger age groups. So you see there's a stepwise progression from adults to teens to younger children. In the Pfizer study, the first step under age 12 is to look at 5 to 12-year-olds. And then they're going to look at 2 to 5-year-olds. And then after that, even go younger to about 6 months. These studies, once they're done in adults, the ones done in teens and children are called bridging studies. They don't need to be tens of thousands of volunteers in the pediatric studies. And in point of fact, the Pfizer study for the 12 to 18-year-olds enrolled 2,000 youth. It showed safety, similar to what happened with the adults, and it showed that a good immune response was elicited in the youth who were part of that trial. So it's a very thoughtful, careful, stepwise progression through the pediatric age span, starting from older youth to younger children. So it's a well worked out process. It's accelerated a little bit now that we have a quote unquote emergency situation with the COVID pandemic, but it's done very carefully, thoughtfully, with a lot of oversight. And even once a vaccine is approved, like it has been for the 12 to 18-year-olds now, there's very careful collection of any adverse event, any adverse events that are done systematically. If a signal for a problem comes up, it's looked at very carefully and aggressively. And if it's serious enough, there may be a halt to immunization until things can be investigated very thoroughly. So that's a general process, stepwise process, and that's why we're seeing availability for 12 to 18-year-olds now. But by the end of the summer, most of us expect to have 1 or 2 of the vaccines available for the school-age kids between 5 and 12.
And quickly, Paul, do we expect J&J, AstraZeneca to also be looking younger than 18?
Yes, they do. They already have trials in the field. They're a little behind the 2 mRNA vaccines, the Pfizer and Moderna, but they also are following suit. And do understand that there are more than these 4 vaccines out there. There are a slew of additional vaccines which are in earlier stage development, which will eventually get to the point, hopefully, of consideration for approval by the FDA.
Great, thanks. So speaking of those adverse events and concerns, we've heard, and we have sort of 3 questions in our Q&A that are around gynecologic concerns, infertility, miscarriages, and changes to menstrual cycles. Mary, any data on that post-vaccination or even after COVID-19 infection?
Let's see. I may need Paul's help with this, but generally side effects of vaccines, historically usually occur within the first 6 weeks after a vaccine is given. And there's no evidence now that any vaccine causes fertility problems. There's no evidence that it would affect puberty, pubertal development. The vaccine is safe for pregnant women. Among the millions of people that have been immunized, there are women who got the COVID vaccine while pregnant. There were women who became pregnant after getting the COVID vaccine. I don't believe there's any evidence about concerns with fertility following COVID vaccination. But I defer to Paul.
Mary, I would agree totally. Note that there is a very active, relatively large trial that's about to be completed where they're enrolling pregnant women. As you mentioned, there have been a number of pregnant women who have received, any or all of the vaccines that are available right now without any significant safety concerns. But there are specific trials that are enrolling upwards of 4,000 pregnant women, and we expect the information from those trials to hit the street by the end of the month or in July sometime. There have been no safety signals there to my knowledge yet. So it does appear to be safe and effective in pregnant women, but more specific data should be coming shortly.
And I believe double check me, Paul, that some early data would suggest that pregnant women who've been vaccinated have some protection for their newborns as well. And Mary's nodding as well. So this is not uncommon as we see the antibody protection can cross. So, that is even more beneficial than just reassuring. Mary, now we're getting to questions. Thank you to the audience. We have time. We certainly had questions in advance that we knew people were thinking about, but question about how you discuss with patients the unknown long-term effects of the COVID-19 vaccine. And in fact, every time we bring a new vaccine to our kids, we don't have long-term experience with it. So how do you help families think about that risk benefit?
Yeah, that's an important question, isn't it? I mean,
And anyone
again,
else in the panel can also
Yeah.
jump in with Mary too.
yeah, again, the parents that are sort of the most conscientious and thoughtful tend to be the ones that have the biggest concerns and worries about vaccination generally. I would say that the COVID vaccine is kind of unique in that we are following for side effects in such an aggressive and comprehensive way. I'm sure people that have had the vaccine have been enrolled in this follow-up program where they text you and email you and just are constantly gathering information about possible side effects. So I feel like it's really, really robust. And I also feel that these two slowdowns that have happened, with the myocarditis question, the blood clot question, to me is incredibly reassuring, that as soon as just the smallest inkling that this might be of concern, they stop, they look at the data. I feel like the safety of this vaccine is being looked at with a fine-tooth comb. Having said that, by the time the vaccine makes it to children, there are hundreds of millions of doses that have been given to adults. So I think for parents who feel like, hey, I don't want to be the first one in line, you can't be. They did in Vermont, at least, it was age banding. It was over 85, it was over 80, it was over 75. And by the time you get down to kids, there's just been a really robust number of doses given out. So I understand and sympathize with parents who feel like they don't want to be the first ones in line. And that is just not the case with this vaccine.
Yeah, I think these are really good conversations that you can have with your primary care practitioners to discuss that. But there's certainly voluminous use, broad use of the vaccine. And indeed, we don't have years and years of experience with it yet, but we have historical experience with other vaccines. Another challenge.
Excuse me, Keith. And one thing I think I should just point out, at least what we're seeing in primary care is, yes, it is true that children are not at as high risk of death and disease as adults. But at least what I'm seeing in the office is this has been incredibly costly to children in terms of disruption of school and social life and mental health. And, I think it's so important that when kids go back to school, as many of them are vaccinated as possible and their lives can get back to as normal as possible. And their teachers are vaccinated. And I think it's hard to overstate just how costly this has been for children.
Right. So I think thank you, Mary, because we've noted that the virus itself may have spared the worst of children, but the pandemic certainly has not. And, that raises another question. It's Ellie, I'll throw it your way, but anyone can chime in. These are speculative, but one of our participants wondered about schools that are thinking about making masks optional in the fall and how would this impact the kids who are not vaccinated? I presume there would be policies in place, but I think that's the risk benefit that schools are having to weigh. I'll let you think, Ellie. I want to push back to what Paul had said, or Mary had said. We annually, one of the reasons, in addition to protecting kids, but one of the reasons we vaccinate all kids and young adults and all of us for influenza is to help to secondarily protect the most vulnerable elderly. And I just appreciate the beauty right now in that the older folks got their vaccines first in this, appropriately for the reasons you've heard tonight. But this is them helping reverse the course in some ways, because the vaccinations of the older folks is going to provide some degree of that herd immunity to protect the younger kids. So it's a nice turnabout. And in the fall, we'll be pushing kids to get their flu vaccine again to help protect, it's a multi-generational effort to help protect all of us. Any thoughts, either Mary, Paul, or Ellie, from what schools might look like in the fall with a hybrid or a blend?
Yeah. Oh, sorry.
No, go ahead, Mary.
Well, I think the summer's going to be all right for kids. I do. I think that kids are going to be, they're going to be outside. They're going to be with their friends. They're going to be playing. I think even the sort of start of school could be all right. My worry is that once, and I think schools have done a wonderful job of having outdoor classrooms, but the reality is it's pretty hard to swing that in December. And my worry is that, as disease gets less, as people get a little bit complacent, they sort of are having a great summer and they kind of forget that this thing can come roaring back in the winter, and we'll be less able to do the outdoor classrooms. And I'm just really hopeful that people will take advantage of this opportunity to get vaccinated now and as soon as possible in the fall, so that we don't have another winter of our discontent, I guess.
And I'm not on TV, but my producers whispered in our ears that actually in the state of New Hampshire, I believe this is Manchester, New Hampshire, schools have just changed their rules for masks in schools. Effective immediately, they will only be required of moving about the building, but in classrooms, staff and students are not required. I'm presuming this is because they're maintaining 6 feet of distancing. I don't want to read in, I haven't read this policy, but I suspect in the classrooms while seated at their desks, they do not require masks. You can certainly choose to wear a mask at all times. And then when there's mingling, they will be wearing their masks. This is probably the stepwise progression we will start to see as we continue to achieve much, much lower case rates, thanks to the vaccinations that we're seeing so many people adhering to. Did I interpret that wrongly, panel? Ellie, go ahead.
I just wanted to say, similar to Mary, that ideally we will be unmasked, but things may change as we move into the winter, and we cover an enormous geographical area here at CHAD. So there may be differences based on location in terms of rates of illness or school and classroom size. So I think that, knowing that everybody's trying to work together to keep people safe is important to keep in mind, and that hopefully we don't have to go back to as stringent a masking policy for all of us everywhere. But, keeping in mind that someone may have a reason for wearing a mask. It doesn't mean they're not vaccinated or don't believe in vaccines. There may be some other personal things we don't always have insight into. And it gets hard to compare what's happening in the Upper Valley to down here or, someplace else across our system.
Yes, excellent. So I am reminded for the World Health Organization, the chief, when we started this pandemic, noted, as Ellie said, our shared humanity is our antidote to our shared threat. And it's constantly a reminder that kindness and grace for people and all that they're doing is always important. So I think we have time for one last question. And Paul, I'll shoot it your way in terms of, a lot of these have been emergency use authorizations. Do we know anything about time frame from the vaccine manufacturers seeking sort of more full FDA approval, what that process looks like?
Yeah, so Pfizer has already submitted their request for full FDA approval. It's been multiple weeks, so we expect maybe this month or July to have a reading on the FDA's thoughts about full approval, and we expect full approval to come forth, but we'll see how that plays out. Moderna also, I believe, has already submitted or is just about to submit for full FDA approval. So this process of vaccine development is unfolding. It's moving into children, but the full FDA approval is working in parallel. So that should happen, certainly early summer, if not late spring.
Excellent. So we are Just thrilled you've joined us and stuck with us for 45 minutes on a summer evening. We, again, reminder that over a third of New Hampshire teens and more than half of Vermont teens have already had a first dose vaccine. Northern New England is showing the way on how to end a pandemic. CHAD is spread across the region, so it's difficult to tell you exactly where to pursue your vaccines, but pay attention to chadkids.org. We have a COVID-19 page, help link you to the state sites. Nashua is picking up the baton in southern New Hampshire. Lots of sites for walk-ins I see in Vermont, including some school districts have done school vaccinations, so please take advantage of those. We probably believe, or we do believe, we will be back in the fall with another panel as both hopefully younger children are eligible to receive the vaccine and schools start again. So in the meantime, enjoy your summers. Watch, this will be recorded and at the YouTube page for those who have hearing impairments on captioning. And once again, my thanks, Ellie, Mary, and Paul for your wonderful expertise. Night, everyone.